Hi and welcome to the Physiotutors podcast, episode 49 with Mike Reiman. Mike is a physiotherapist, active clinical researcher, educator and mentor with a special interest in the hip. He's also an associate professor at Duke University and an adjunct professor at Wichita State University. In this episode, we will talk about Femoroacetabular Impingement, abbreviated as FAI. You will learn more about FAI morphology and the development of FAI. Mike will elaborate on the epidemiology of FAI and what can trigger symptoms, and the prognosis in regards to the development of hip osteoarthritis. Of course, we will talk about diagnosis and physiotherapeutic treatment and finish off with a discussion about surgery for FAI. So make sure to listen to the whole episode. Enjoy. Hi, Mike. Welcome to the podcast. It's an honor to have you.
Hi.
We have a lot to talk about. We have a lot to talk about and no time to waste. So let's jump right in. My first question is, what is FAI?
Yeah, so thanks for inviting me. I'm honored as well to be on here. FAI probably depends on who you ask. So I was fortunate enough to be on the Warwick Agreement, and I think that was in 2016. We defined it as a motion-related disorder. We suggested that there needed to be three components. The patient needed to have symptoms, first of all. They needed to have clinical signs, and they needed to have imaging that correlated with those clinical signs. There are two main types, and then the combination of those two is what's called mixed, which seems to be the most prevalent. But essentially, it is a bony abutment of the femoral head against the acetabulum and the acetabular rim. That bony abutment can come from either the femoral head being too large, which essentially is what a cam is, or the acetabular rim overextending the femoral head too far. Theoretically, it's proposed that that bony abutment happens either sooner or too much or too frequently or whatever, as a result of either a large femoral head or the overlapping of the acetabular rim. I think it's important to note that this was all kind of based on Reinhold Gans's work, where he saw this type of stuff in surgery. And so this is based on theoretical concepts. The definition is, most people tend to go off of the Warwick Agreement. There are issues with each component, and we probably could get into each one of those if we wanted to. So.
Okay, yeah, clear. And thanks for your answer. And do we know how it develops? Is that during adolescence, or can it still develop when we are older?
A lot still needs to be determined on that. But what we currently know is Renji Agricola is doing some really cool work on this. A lot of modeling work. He is suggesting, and this is probably our best theories currently, is that the epiphysis, the physial plate, extends as a result of loading. So pretty much specific adaptations to impose demands. So similar to what we learned in the shoulder with the humerus, from Crockett's studies in 2003, where they looked at throwers versus non-throwers, and they found that throwers actually had torsion of their humerus. What we think happens with FAI, specifically CAM, is that the above the growth plate, that shifts, and then that makes the head less round but larger, and that's part of the current theory. Something going into this that I think we need to take into account as well is torsion, similar to the shoulder. And so there are things where, and we can probably talk about this later too, is a lot of people will have asymmetry or lack of congruency in the amount of internal rotation they have versus external rotation. No. And there are some theories that could lead to impingement as well.
Okay, yeah, thank you. And if you describe a typical patient that comes into your clinic with FAI, how does this patient look like according to, if we look at gender, age, and the sports that they do?
There are, I think, let me maybe go back one step here, because I think, and this will probably get into, like when we get into exam and everything, is if we look at how these studies are done, and it's pretty much out of necessity, is, so let's take where I'm at, for example. So at Duke University, we have a large hospital, we have multiple outpatient clinics, we have physiatrists, we have physicians, we have internal med, we have all kinds of physicians and clinicians. If we captured all of the patients, all of the hip patients that are at Duke, we would have this huge, let's say 10,000 or whatever, or that's easy math, let's say 1,000. The ones that are being captured in these studies for FAI are a very small percentage of that. Because what happens is all these patients go to see the doctor, or some, and even some of them don't, right? So we know a lot of people that have hip pain and don't go see a physician. But if we look at all the hip patients, let's say in Durham, North Carolina, where I am, which is where Duke is, and those that get better on their own, they don't go see anybody, or those that go see a physician, some of them might have adductor tendinopathy, some of them might have osteoarthritis, some of them might have osteopubitis, some of them have intra-articular pathology, and some of them have extra-articular pathology. The ones that end up having FAI are a very small percentage of that. Because what happens is they don't get better as they're treated along the line. So the ones that end up in the orthopedic surgeon's office are predominantly, if they see FAI, they are predominantly people with FAI. So if I go to the surgeon's office that I work with, I walk into his waiting room, and let's say there's 10 patients waiting, probably 9 out of 10 of those people have something intra-articular pathology going on because they've been farmed through the system. This is at least how it works in the States. They started in the whole cohort, and by the time they went to see the orthopedic surgeon, now they're in a small, very small percentage. So a lot of these studies that are done on demographics, special test, those types of things, those patients have a large pre-test probability. Specifically, what we know from those studies, as far as demographics, they tend to be in the 20 to 40 years of age. Males are, men are typically more likely to have CAM. Women are more likely to have pincer, the head over, or the rheum overextending. They're more likely to have deep-seated groin pain. They're more likely to have intra-articular, this pain that pinches. If they have labral pathology, it may click and may have mechanical symptoms. But again, those are kind of a small subset of people that have pain and a small subset of people that have groin pain. Groin pain can be a lot of things, and so it can be hard to differentially diagnose.
Agree. And it's maybe a great segue to my following question, which is that there's a lot of people with FAI morphology, but no pain. So how many people with FAI morphology are asymptomatic?
Probably depends on who you ask. So if you look at the studies, they're probably somewhere. So Jonathan Frank did this cool study in about 2016. And what they did is they had imaging of people that came in for lower intra-abdominal type of pathology, suspected not to have any hip pathology. And that's kind of where these types of studies get done is, they happen to capture the hip and because they were looking for something else. In that study, what they found is about 40 to 60% of those people had either a large femoral head or, a rhin that overextended the femoral head. What was very interesting is in that study, both athletes and non-athletes, almost 60 to 70% of those people had labral pathology, had labral tears. And I forget the exact mean age, but it was lower. It wasn't, these people weren't 70 years of age. I think it was probably in the 40s. So there are a fair number of people that have imaging findings suggestive of it and don't have pain. I think a good question comes from that, though, is, so they didn't have groin pain, but, is there any correlation to what they were complaining of and potential hip pathology? And we just simply don't know that.
And what could be a possible trigger? Because if we have a lot of people who are asymptomatic, and I mean, they probably had FAI morphology for quite a while. Like, what could be the trigger that they now all of a sudden develop pain?
If you look at the studies, these people are pretty frustrated. I think it is definitely getting better. But if you look at like Keeney's study, in 2016, and then he did a follow-up study in 2013. So, a few years ago, these patients that tend to have this pathology that we deem as FAI, they tend to have seen, 3 to 4 providers. They've tended to have pain for 2 to 3 to sometimes 4 years. And they have had physio before. They've had perhaps injections. And I think this kind of gets into some of what we may talk about later is why they probably want to have surgery. I think a lot of it is, what I look at is, if a patient comes in and I'm suspicious of them having a larger than normal femoral head or whatever, and let's say they're 28 years old. What I know is remember from Agricola's work, as we talked about how that extends when the growth plate's open, that physeal plate extends. When the growth plate closes, that no longer extends. So the theory is that once somebody's growth plates are closed in the femur, that's when the cam is pretty much done. Of course, you can have people that lay down bone and other types of things. But kind of my point here is, if I have a 28-year-old that has been diagnosed with FAI and they've had pain for a month, they've probably had that large femoral head for multiple years. So from my standpoint as a clinician is, why are you having pain for 1 month when that femoral head has been larger for multiple years? And as a physio, there's nothing that I can do about a large femoral head anyway. So my approach is, what changed 1 month ago? Are you doing something different in your training? If it's somebody at work, are you doing different types of activities? So that's pretty much what I focus on. And then I've tried to focus on, okay, that activity is bothering you. Can I modify that activity? Can I change it to something that is less provocative? Maybe have them do it less frequently, take a break like I try to change their activity that is provoking and see if I can modify it. Because to me, I like the word that you used, Kai, the trigger is like, what set it off? It probably wasn't the large femoral head. Now that probably could be some of it, but I think to me is like, what changed with their activity? So how do I need to modify their activity? What do I need to change? And that's pretty much what I focus on.
Yeah, pretty much similar to other pathologies
Correct.
as well, I think. Thanks, Mike, for your answer. And if we look at prognosis, like, is there an association between people who have FAI and who later go on to develop hip osteoarthritis?
Yeah, I think prognosis is huge. And that's something that I tend to focus on with my rehab as well, is, looking from a standpoint, okay, what can I modify? And if I can easily modify their squat, for example, like, I think they have a better prognosis. Now, the difficulty with that is, can they actually do the way we modify? I mean, is that amenable to their sport and their activity? From a standpoint of progression to osteoarthritis, this is a huge point of contention. I don't even know if it's a point of contention, but it's what some surgeons will sell as why surgery needs to be done. The simple answer is we don't absolutely know, because to truly answer that question is we would have to do really long longitudinal studies, 30 years, 20, 30, 40 years. Now, we do have a couple of studies that have been, one was 19 years, I believe. And in that particular study, and there's been some Czech cord studies, there's been Chingford studies, there's been a couple of studies in the United States for the Johnson Project. Some of those shorter term studies, like the Czech study, those were over 5 years. And the problem is they started with adults that were older, so 35, 40, 45. if we truly want to capture this, is we probably want to capture those people from when their growth plates close, and then follow them out until, and see if they have osteoarthritis. Those are really difficult studies to do. What we do know in the longer term studies, some people do develop osteoarthritis. Some people don't. And in that 19-year study, 12% of the population, and I forget I think their alpha angle was pretty large. I think the alpha angle, so how large the femoral head is, I think those with a 78-degree angle, which is pretty large, most people would suggest 60 is a cutoff. Those that had 78, I think 12% of those people developed osteoarthritis. So you can look at it a couple different ways. You can look at, 78 is the cutoff, but how I look at it as well, and not to minimize those 12%, but like 88% didn't develop osteoarthritis. No. So I think some people, what we currently know is some people will develop, but probably the majority won't. The difficult thing is, how do you prognose who will and who won't?
Yeah, can we say that the majority will probably not develop osteoarthritis, but that if you were diagnosed with FAI, that you have a higher risk of getting osteoarthritis later on compared to people who don't have FAI?
I think that's honestly a great question, and I don't know if I can best answer that. I think that would probably need to be from people that are definitely focused. I mean, that is their, we're looking at genetics. There are genetic markers for people with osteoarthritis. So from a standpoint of somebody that researches and treats and does people with FAI, I think there are other rheumatological things that probably have a bigger factor, which, some of these people with FAI do have rheumatological issues as well. So I don't know, to be honest, that's a tough question to answer.
That's totally fine. Sometimes in research we have to say we don't know.
Yeah, I think being comfortable with uncertainty is, as you can see, I'm older, and I have honest conversations with my patients, and they will ask me the things that it's like, does this mean I'm going to have osteoarthritis? Do I need to have surgery? And if I had to very succinctly say, I would probably say, I don't know, it depends, but then I try to qualify what it depends on. And I think all patients should go through a trial of non-surgical conservative rehab. I think, from Joanne Kemp's works, that would suggest that probably needs to be about 3 months. I think that also, though, if somebody is progressively getting worse, not doing better, you don't hold on to them for 3 months just because that study says that. So, yeah.
Okay, I think we'll go into treatment and physiotherapy and surgery in a minute. So maybe to move on, say I have someone with hip pain in my clinic. So where do I start?
So I think subjective is huge. And if you look at medical studies, subjective will give you about 74 to 90% of your diagnosis. I think that it's as well, when I was a novice clinician, I pretty much went through subjective by doing the check marks. I think a good subjective takes, a good 30 minutes, and that's hard. So sometimes I have patients come in that are in a lot of pain, and we don't really end up doing a lot of exam. We do subjective, and so, they're going to tell you things like pinching pain, it's deep-seated groin pain. The problem is if they have chronic pain, now they have pain in multiple locations. There are some studies, especially out of St. Louis, that show that some of these people do have lateral hip pain, they have buttock pain, they have SI pain, they have low back pain. Now, is that concomitant pathology or is that a result of them compensating with activities and those types of things? So that's difficult. So I think a good subjective exam, and I could talk a long time for that, but I'll kind of move on. I think looking at impairments is very important. I measure range of motion. And the thing with range of motion is, what does the within range of motion? So as I'm going through the range of motion, how does it feel? Are they guarding? Are they protecting? Is it, does it move with ease? And then when I get to an endpoint, is it a firm endpoint, which the hip should be? Or do I have a bony endpoint? Do I have an empty endpoint? Like, those are all important things because those are probably prognostic things, but also directing my treatment types of things. I think your impairments are probably not going to tell you a diagnosis because a lot of people have weakness. A lot of people have limited range of motion. They're probably going to direct your treatment more than anything. I think the difficult thing with coming up with a diagnosis for FAI is because of how we did those studies, those cohort studies and high pretest probabilities, the majority of our exam is ruling out or excluding. So, for example, Fader's test, which I published a lot on, is pretty much a sensitive test or a ruling out test. And so it probably only is helpful is if it is negative. It helps exclude FAI. But the problem is multiple people are going to be painful with Fader's test. So I think it's a holistic exam. I think it's looking at subjective history. I think it's looking at social and psychological. A lot of these patients have mental comorbidities that actually get a little bit worse as a result of surgery. So I think what it is figuring out what type of patient presentation do you have and addressing what the impairments are, whether they're biological, psychological, and or social.
Yeah, and what would give me a hint, for example, to distinguish, because like if I look at the Doha agreement, for example, that's something that we use in practice, what would help me to think more of FAI compared to the other 3 or 4 categories that we have in the Doha agreement?
That's difficult. And so I think I think it depends on, like I do this talk where I talk about this kind of stuff, but I was presenting to some athletic trainers and some people that were working in high-level sport. If you look at those studies, if you look at simply prevalence alone, the majority of the people that they're seeing are probably going to fit in the Doha agreement. And because intra-articular pathology is not as common, but it does happen. Somebody acute. So I think you look at mechanism, and if you look at an athlete and they have a stretch mechanism, or in soccer they go for a 50-50 ball, like I'm leading toward, like I have a strong predilection towards adductor pathology. If the issue is, like if I do the adductor squeeze test, a lot of my patients in the hospital have a positive squeeze test. But remember, my patients have probably already been treated by a physio, been treated by an athletic trainer, and they're not getting better. So I think it's look at who your patient represents, how long have they had the pain, what was the mechanism, those types of things. Look at the environment that you're in. Yeah. If you're in a traditional outpatient clinic and you're getting patients from a surgeon, so at least in the States, and you're getting a patient from the surgeon, like I'm leaning towards intra-articular pathology. If I'm working on the pitch and this happened a couple of days ago and they haven't seen a surgeon, like I'm leaning towards, Doha agreement types of pathologies. No. Those two, the Warwick and the Doha type of patients, they can coexist. And so I think the big thing is they're going to change what you do as a treatment.
Yeah. Anything else when it comes to signs and symptoms? Like, would you say patients with intra-articular hip pain, for example, they don't like the rotations compared to other groups, or they have more problems with deep sitting?
Definitely, those could be some key things. I think ruling out the lumbar spine, so doing a good comprehensive differential diagnosis. Those that are more likely to have intra-articular pathology are probably going to, the rotation, as you mentioned, is probably going to be a big one. And I think you need to look at your cohort too. For example, is if you look at for example, like a hockey goalie that does the butterfly technique, those studies will show that they lack external rotation versus most other patients will lack internal rotation. Somebody with intra-articular pathology probably is going to have limited internal rotation. They're probably going to have guarded and or protected. I don't necessarily like that word, but I don't have a better word. Within range of motion, their infill is going to feel different than somebody that is asymptomatic. So it may be firmer, it may be hard, and or it may be firm and symptomatic. Versus people that truly have DOA won't necessarily have those types of presentations as far as limited internal rotation, limited within the range of motion, and a guarded and or abnormal infill.
Yeah. And okay, yeah, and if I move on and if we say, okay, like how can we know for sure, like how is it then going to be medical imaging to be really sure about what's happening?
According to the Warwick, yes, that would be part of that criteria. Yeah, so of course having symptoms in the first place, having a clinical presentation. So kind of the ideal Warwick patient, I guess, would be somebody that comes in, states as deep-seated groin pain. And Thomas Bird in Nashville talks about the C sign, where it's this deep pain inside the groin. You can't palpate it, you can't touch it. So they would have that type of presentation. If they had labral pathology, they're probably going to have mechanical symptoms, so clicking, catching, pivoting types of clicking and catching. And then with your clinical exam, so that would be your subjective exam. Your clinical exam, potentially you're going to find probably limited rotation, probably IR, probably guarded, probably in-range pain, probably going to find some weakness. But again, that's not necessarily diagnostic because a lot of other hip pathologies will have that as well. Probably going to have a positive faders, even though it's a screening test. May have a positive Thomas test if they have mechanical symptoms. So like a consistent clicking as you lower the leg down, it'll consistently click and catch based on McCarthy and Bisconi's work. And then again, in the ideal patient, they would have diagnostic imaging that matches that. So an AP or frog leg view would show a larger than normal femoral head and or a rim that extends over the femoral head too long. In there, we also put, and this is my bias, I personally like intra-articular injections for diagnosis. And I think that they need to probably be ultrasound guided because the accuracy is a little bit better. There are some issues with that, of course. So, but again, so the ideal patient would have an AP profile, a frog leg or lateral view that suggests FAI, and then an intra-articular injection that gives them short-term pain relief that then quickly, comes back within, 48, 96 hours or something. That would be kind of your ideal patient.
Okay. And do you think if I see a patient like that, is it necessary to get imaging, or can I just start treating and go from there?
That's
if I have a suspicion of FAI.
So that again depends on who you ask. Is if you ask a patient, that's probably what they want, at least in the States.
Yeah.
The surgeon probably wants that.
Also
the surgeon
here.
probably wants that from a treatment planning standpoint. What I always teach in my courses and with my students is that going to change what I do? And probably 99%, well, I don't know, a large percent of the time is it's probably not going to change what I do. Now, if I'm concerned, and I'm concerned about, red flags, or, I have a younger adult that has very guarded, very sharp infill, painful, and I'm concerned about a skiffy, I'm going to have imaging. So from a standpoint of where I'm at is majority of them, by the time they come to me, is they already have the imaging. I probably tend to not, if I know there's nothing serious to worry about, I don't even look at it, but that's what the patients want to talk about. In the ideal situation where I would work is I would not do imaging unless I was concerned and the patient was not making progress. But that is a big component of the Warwick diagnosis.
Okay. And if we move on towards treatment, and maybe one question before we move on to that. You already touched on impairments that people have compared to the healthy group. You mentioned often lack of internal rotation or different end feel. When we look at muscle strength, is there a difference in people who have FAI compared to healthy subjects?
There are definitely some published studies on this, and there are definitely studies that suggest that. Joanne Kemp has done a lot. A couple of Denmark studies. So Lars Ishoy, I got my PhD through that group, and Christian Thorberg and Per Holmick, and then there's also another group in Denmark, Bert Lund, and those folks have done a bunch of cool stuff, and they've also done some stuff on people with dysplasia. And there's been a couple of groups in the States as well. The different groups find different things, which probably is not necessarily not to be expected. And probably I would have to look, but I think all groups have been implicated. I just recently saw a study that found that people with internal rotation, that seemed to be the biggest discriminator. There are some published standards out there, and so especially in dysplasia, the problem is they are on like 40-year-old females. So how do I take that data and correlate it to an 18-year-old male, for example? So I think side-to-side differences and handheld dynamometry is a big thing. I think I think those are very important. But yeah, these people do have impairments. They do have weakness. Some of Joanne Kemp's work suggested that if you get their hip extensor strength back, that probably helps more with prognosis. We probably need more studies to replicate that, though.
Okay. Then if we carry on and we say someone came into your clinic, you suspect FAI, he had imaging or not, how would a typical treatment session start? And maybe let's start with your first session, and maybe we can touch on like how a session would look like later in the process.
A lot of it is education. Patients are coming. Yeah. Think about, and again, I can only speak for the States, how a patient goes through the health system in the States is, and this is no fault with the surgeons are busy, and sometimes they only have like 15 minutes with them. So they're going through the system, they're going to radiology. The surgeon says, okay, you have a large alpha angle, probably try to explain it. But if you look at studies, patients remember about 50% of what they're told. And think about somebody that doesn't have really high medical literacy. So I spend a lot of time, asking them, do you understand what your diagnosis is, what the surgeon told you? So a lot of it is that. Then also kind of getting to is, some motivational interviewing, like what are your goals? Where do you want to be? What is your definition of, so when we get done here, what is your definition of success? What, like I look at expectations, which are some really cool studies on expectations. And, excuse me, like what are their expectations for non-surgical and surgical rehab? So a lot of it is kind of framing like where they're at, where I'm coming from. Are we on the same page, kind of getting therapeutic alliance, that type of stuff. And then it's like doing a very systematic, very progressive rehab program that's monitored over a period of time. And like I'm very open and honest with my patients and say, hey, by 4 weeks, here's where I would like you to be. And this is where I think if you measure their expectations and they want to be playing sports in a month and they have some prognostic factors that aren't very good, then I don't be really negative with them the first time, but like over a few visits, like, how realistic do you think you can be at that point? And so I think setting expectations and doing that stuff is very important. I think it's also important to have an open, honest conversation about uncertainty. So when they ask me, like, do I need surgery? Is this going to progress to osteoarthritis? I think I'll answer similarly to what I did before, but using patient-friendly language. like saying, we simply don't know. But the good thing is you don't have any red flags. You have a lot of good prognostic. I don't use prognosis. A lot of variables that are in your favor to do well with rehab, and I use that type of language. And I'll try to get, I am very objective. I measure their strength. My focus early on is looking at work capacity from a standpoint of, how much, and because if you look at the literature, what is it? Less than 20% of patients are getting 150 minutes of moderate activity a week. And that's a lot of my patients. So what is the low-hanging fruit? It says, hey, can we go for walks? Can we ride a bike? I try to get them on some type of a physical activity. And then I use RPE, I use time frames, and I try to objectify all those types of things early on and throughout their rehab.
Yeah. And any things that you advise them not to do? Like to calm down the symptoms in the beginning? I use this little acronym that and it's based off of Greg Lehman's, calm stuff down, build stuff up. Yeah. Essentially, I just expanded on that, and I call it EPIC return, EPIC. E means education, P means progressive loading, I is individualized to the patient, and then C is considerations like what does their insurance say? Are you the best patient to treat them? How many visits do they have? That type of stuff. And so, early on is if we could just simply avoid the provoking activities and let's get this calmed down. Now, I still I have all of my patients squat. Now, it might be wall squats, it might be a Smith frame squat, it might be hands and knees, quadruped rocking type of, we tend to work on that motion, but it has to be in a favorable position. And I have them measure pain levels, RPE, time duration, all that stuff. Yeah. Okay. And if we look at specific muscle groups maybe around the hip, is there some? You mentioned hip extension. Is there something that you would focus on in particular?
So I probably would look at I would try to extrapolate to their age and their category, and looking at essentially what does the handheld dynamometry tell me? How much of a deficit do I have side to side? There's problems with LSI, of course. There's also problems with age-matched controls and that type of stuff. So essentially is so this is where it becomes anecdotal. What do I think is the biggest rate limiting variable? So like I said, Joanne Kemp showed that extensors are very important. Yeah. Last, Ishoi showed that with high-level athletes as well. Nicola Castratelli showed that hip flexors are a big variable. He did a really cool study where he did repeated hip flexion over 20 repetitions because he thought it was going to be an endurance issue, and it was a strength issue. So kind of a winding answer here is I would try to focus on what I thought was the biggest variable. I will focus probably in the frontal plane first, so abduction, adduction. I will work on sagittal plane, probably in a controlled range of motion. Oh. If they're pinching at 90 degrees, we might stay, 60 to 80, or even doing isometrics. A lot of cool studies show that you get physiological overflow of strength. So, I still work the painful motions. We just work them where they're not provoking.
Mm. Yeah, clear. So, you look at the patient, look at the impairments. You might start with the frontal plane, move on to the sagittal plane then. And do you also add any core work for those patients? Do you work on core strength?
Yes, I do. Probably depends on how you define core. Is that planks and sit-ups and that type of stuff? So I think core is huge important. My approach to core is dynamic. So I'm a big fan of chops and lifts and pale-off presses, and we have a cable column that I use a ton of, and or bands or kettlebells. So I tend to prefer for lack of a better term, functional movements, chops, lifts, overhead presses, carries, that type, those types of things. And so that's how I get my core. If they want to do planks and they want to do sit-ups and they're not painful, go ahead. Like we probably won't do those in the clinic. They can, of course, do those on their own. But my approach would be more dynamic core, I guess you might say.
No. Yeah, I think I mentioned it because I read something about the side plank that was less in FAI patients compared to the healthy group. That's why I came up with that question.
No, and there, I think I remember that study as well. And if you look at, and I won't get into there, so EMG is awesome. There are some issues with it, and that's maybe another time. But if you look at EMG of gluteus medius, side plank is probably one of the highest activities. And so definitely side plank is a good activity to get high EMG activity. That's an isometric activity that's probably not going to provoke them. So yeah, it's a great exercise.
Yeah. Okay, and say so you started your rehab process, and they are a couple of weeks further. They are maybe even able to squat down to 90 degrees, for example. How do you prepare them to return to sport? So how does it go further? And how, maybe that's also the next question. How much time does it take to return to sport with FAI?
Those are a lot of great questions. I think if you look at the literature, so we published a systematic, meta-analysis, then we looked at 35 studies. And in those 35 studies, it took an average of 7.5 months to get back to sport. The issue with those studies in our study is, like, how do you define return to sport? And that's a huge issue. And is it simply being on the roster, which some of the studies said, is it, if they're in baseball, is it having one at bat? So that's a, we could talk about that for 30 minutes. So I think that's an issue. I think as far as how I get to that point is I have a strength conditioning background, and I tend to try to use similar, I don't do a traditional periodization plan, but I definitely have phases. So I have a phase where we have a high work capacity phase. And so it depends on what the athlete, if it's a long distance runner, we might do much more work capacity. Wow. If it's a year ago, I was working in our football training room. So explosion and power. So we would probably use more of a traditional periodization approach where, we would go from work capacity to strength to power, and decreasing the load, increasing the intensity. So I plan it out, and I set it with the patient and say, does this seem like a good plan? But essentially is when a patient comes in to see me, is we do some type of a dynamic warm up at first. And so it might be A walks, B walks, and those types of things, or it might be, if they're really irritable, it might be, or post-op, you might be riding the UB, doing the UB. If they can tolerate it, might be doing the bike or the elliptical machine. I like ergometry because I can get their RPE, I can even measure their heart rate, and I can get an output on that. And I'm a big fan of, using the 6 to 20. So I still have them do 1 to 10 RPE, and I just extrapolate it to 6 to 20. If somebody tells me, oh man, that was an 8, but their heart rate is 100, those things don't match, right? And so then I'm thinking, well, okay, there's other things going on here. Maybe, catastrophization, fear, other things that are going on. So I think it's important to measure RPE and then also measure the heart rate from that standpoint. But I also measure the output. So, Tim Gabbett's arbitrary units. And I know there's issues with that, but I want numbers. And so then it can be if somebody comes to me in 3 weeks and said, man, we're still at 20 minutes. But I said, yeah, but look at your output. Your output is 15% higher. So that's pretty much how I use that. And your pain is only a 3 versus it was a 5. So that's tend to be how I do that. And then, like, I always build work capacity first, and then strength. And then if they need to, then we'll go to power. And we integrate some of that strength and power at the same time sometimes.
Okay. Thank you for your answer. And how successful is physiotherapy when it comes to treating FAI? I mean, we will touch on surgery in a minute, but how successful are we?
Not great. So to me is, and I'll kind of get into surgery here a little bit too, is, and we can talk about direct comparisons, but well, number one, here's what I love about what the surgeons are doing is they are collecting data. They are doing tons of studies. We published that return to sports study, I think in 2018, and there were 35 studies. Like if we were going to replicate that study again today, like I would say that's probably close to 90 to 100. So there's a lot more, and other people have published on this as well. And so there's a lot more studies. So the nice thing is they are publishing on what they're doing, which physio needs to do a better job of. The issue with physio is there's not as many dedicated researchers that are in this line of work. The studies that are out there are some favorable ones, there's less than favorable ones. The majority of them are level 4 studies, so cohort studies, and the higher level studies. So there are, I can think of 2 of them that are level 1 to level 2. And there are favorable results. And I know so like Joanne Kemp and other people are doing these bigger studies now. And so definitely we will know in time. But the ones that are currently published, there was a study I think published in California. And what they found is it was favorable. And one big issue, Kai, is like, what are we calling physio, right? And so we don't all do the same physio, which definitely is normal, but like there needs to probably be some parameters. And maybe a side tangent here just a little bit is Lexi Wright published this really cool study where she looked at studies that were out there that did FAI exercises. And now granted, this is published literature. This is not what is being done in the clinic, but only 5% of those exercises involve the transverse plane. And only 5, and I forget the exact numbers, but that was probably the most egregious one. And so the point is that, when you do this personalized therapy, is that really what we would all do? Are we loading them enough and that type of stuff? But that said, is the California study is there were favorable results. But if you kind of dug into that study is, and I don't remember the exact numbers, but some of those patients were still considering surgery. Some of them went on to injections, and then some of them actually did cross over and go on to surgery. But some people do well. And so kind of the key is, can we figure out who are those people? If a patient comes in to see me, like, what are going to be prognostic variables that, hey, this person probably is going to do well with non-surgical treatment approach. And that's difficult at this point because, and who's going to have a good prognosis for surgery? It's probably the person that fails non-surgical.
So physiotherapy is favorable, but we are not doing a great job. So how does surgery do compared to physio?
So this is what's really, really interesting is I think there's 4 or 5 randomized controlled trials that directly compared physio to surgery.
No.
What's very interesting is I don't remember the exact, I think it's 4 or 5, but then there are more I think there's like 5 or 6 meta-analysis on those 4 or 5. So we have a problem. Is we're doing more and what's interesting is the meta-analysis don't say exactly the same thing. I prefer to go with some of what Joanne Kemp looked at and other folks. And if you look at the studies, at 1 year, surgery is definitely more favorable. So those patients tend to do well. Joanne Kemp, when she published her study, showed that the effect sizes were probably small at 1 year. And then at 2 years, there really was not a significant difference. But there are some caveats there as well, is there were more people that ended up going to surgery with the physio compared to having a second surgery with surgery. So there are some caveats with that. And what's interesting is if you look at other areas of the body is, so like the main group that looked at lumbar spine fusions and discectomies, and you look at surgical subacromial decompressions in the shoulder, and you look at the hip and other areas, all of those comparisons of non-surgical to surgical, the 1 year outcomes definitely favor surgery. And sometimes by a little bit to maybe little to moderate. But if you follow them out for longer periods of time, especially the lumbar spine studies, especially at 2, 5, and 10 years, what they did is there are no differences, by those time frames. So that's, that's a lot of information. And what do you do with that information with the patient in front of you is like a whole other level of questions.
I looked at the information you provide, I think, for one of your courses, and I think it was your FAI course, and it said 74% return to sport, 57% on the same level, and only 17% are satisfied and performing on the same level after surgery. That's quite bad. It was quite shocking to me.
Yeah, so that where that data came from is 74. So I kind of combined some studies when I did that, and just to have maybe more of an effect, but is the 74% came from our meta-analysis, which was those 35 studies. In those studies, kind of like what I said before, is essentially 3 out of 4 returned to sport. And there was probably a subset of those studies. I think I don't remember the exact numbers, but it was less than 10. And because then the issue is, like, if you look at Claire Ardern's work, is a return to sport or is a return to performance at the same level, which is probably why athletes are having the surgery. We weren't able to truly answer that question. Our numbers were about 50% going back to the same level. But that same year is Ishoy and Christian Thorberg and Per Homick out of Denmark published a Danish registry study where they looked at patients in the Danish registry. And what they found is the people that returned to performance, that number was 57%.
Wow.
So going back to the same level that they were prior to their onset. And then the 17% came from, in that same study, is, okay, how many of you are back at your same level and satisfied with how you're performing? That was 17%. And then it's funny to hear Last talk about, he's the first author. It's funny to hear him talk about that study. Is he goes, are we just not doing a very good job in Denmark? Which I don't think is the case. And he jokes about it's not the case either. But there has been a United States study that showed very similar numbers, and so I think that's probably more the norm than it just being from Denmark or whatever. So pretty disappointing, to be honest.
No. So would you say, like what applies in general with different pathologies, that first we should go for physio and see if people improve and then go on to surgery, especially if we don't have any data yet on which people could benefit from surgery directly or which people could benefit from physio?
I think that is an open, honest conversation that you need to have with your patient.
No.
As well as a surgeon. And so it depends, is the patient coming to you? Well, here's some of the patients that I get is the surgeon has a 6-week waiting list. So they come into physio until they can get on this, until they can have surgery. So the expectations, if I don't end up answering this, please ask me again. But because I'm going to go a few different directions here is.
Sure, go ahead.
If you look at Mannion's study, he did a really cool study where he asked patients what are your expectations of surgery? And they asked them, what do you think your pain will be? What do your activity level will be? Will you return to sport? Those types of things. And then they looked at, I think it was a year afterwards, and they did a measure called a fulfillment of expectations. Essentially, are you back at the level you expected to be? Are you playing sport? Is your pain where you thought it would be? And the fulfillment of expectations was never met. Was hardly ever met. And where it was the least met was related to pain and return to sport and activity levels. And the most of the patients that I see, they want to get rid of their pain and they want to go back to sport or go back to increasing their activity. Other studies have looked at, and these are some Denmark studies from I think Bert Lund's group, showed that patients that have FAI surgery, their pain is less. They are mostly satisfied, but their activity level is actually worse than it was prior to surgery. And now there are studies that show that some people are doing fine as well. So, like, I don't want to say surgery doesn't work, rehab doesn't work. I mean, the point is that some of these people are the 17%. Some of these people are satisfied, but, they're less active. So I think the difficult thing is, like, how do you take all this information and talk to the patient in front of you, and if they want to, should I do non-surgical or should I do surgery?
No.
What I tend to say is there's published literature out there that suggests you probably need to have a 3-month trial. Now, here's a difficult thing is, let's say they're an athlete and they're trying to get back to sport. If they wait 3 months and then they have surgery because they're not doing well, and now it's another 7 to 9 months, like, they may miss some of that season, right? And so that was a huge problem or not a problem, but that was a huge variable that I had when I was in the training room. And I don't have it as much that I'm not in the training, so I'm in a different clinic every year. And so it depends on who your patient is, what they have to get back to, what their level of success is, and what their expectations are. Ideally, I would like to have a non-surgical treatment trial, but it needs to be a good non-surgical treatment trial. And it also needs to be, if they're doing worse at 4 and 6 weeks, and, like, I'm not seeing a positive prognostic line, yeah, they probably need to have surgery, and they probably need to go on to that. Ideally, we would have, like I said earlier, we would have a patient come in, and we would do what's called kind of like phenotyping, where, they have low mental health comorbidities, they have a positive, realistic expectations, they have a very high internal locus of control, they have a lot of grit, and their impairments aren't very bad. Like, that's probably the patient that's going to do well with a non-surgical treatment approach. They probably would also do well with a surgical treatment approach. So the difficult patients are the ones that have mental comorbidities, poor socioeconomic, they don't have a place to go work out, those types of things. And so those can be very difficult.
Okay, thank you for your explanation. We touched on a lot of topics. Is there anything that you would like to add that we haven't talked about yet?
That's a great question. I think the biggest thing probably is, if people are still listening, is I hope the biggest takeaway would be is to holistically examine and treat your patient. Teach them from a biological, psychological, and social demand. And just, like, really briefly is, I myself have been very guilty of this, is focusing on the biological when there are a lot of studies showing. So, like, Dan Ron has published this and showed that people that had mental comorbidities, mental health comorbidities, those actually got worse after surgery. Surgery did not cause them, but the point is, these patients are frustrated. They may have some catastrophization. They may have depression. They may have socioeconomic demands that aren't favorable. So I try to address, the social health determinants as much as possible, and try to build resilience in your patient. Maybe more of a synopsis versus something new.
No, that's great. Thanks so much. Okay, I'd say, Mike, thank you so much for being our guest on the podcast and for your time and for your knowledge. It was a total pleasure to have you. And also, thanks a lot for listening to this episode. To access the transcript and additional resources, make sure to sign up for a free Physiotutors membership on physiotutors.com and benefit from more useful physio content. If you enjoyed this episode, hit the subscribe button or follow our podcast on Spotify or Apple Podcasts. And also consider leaving a review if you really enjoyed it. And with that said, this was Kai for Physiotutors, and I'll talk to you in the next episode. Bye.